Welcome to Progenesis Academy webinar, session 28. Today's topic is everything you need to know about surrogacy and egg donation. We are very fortunate to have a great panel of experts. We have with us Dr. Serena Chen. She's the fertility specialist at Institute for Reproductive Medicine and Science, New Jersey. We have Dr. Michele Evans. She is a fertility specialist at Pacific Fertility Center in Los Angeles, in California. And we have Dr. Scott Roseff, and he is a fertility specialist at IVF MD, Miami, Florida. We have Ryan Ferrante, and he is assisted reproductive technology attorney at Law Office of Ryan Ferrante. And we have Staci Swiderski, and she is president and CEO of Family Source Consultants, an agency for surrogacy and egg donation nationwide. Thank you so much, you guys, for joining us. So I'm gonna start my conversation by asking you guys to give us a run through the process of surrogacy. How does it look like? And I know we have a panel that go from medical practice all the way to legal, aspects. Can you guys give us a general view of what that process looks like? And I'll start first with maybe with you, Ryan, on a legal aspect, and then we go into the medical practice.
Great. So I know a little bit about your audience. I used to sit where many of the people in your audience used to sit. I was an intended parent myself in a surrogacy arrangement. So you also have an intended parent on your panel as well, if those questions ever need to be addressed. It's okay, first of all, to have 1,000 questions that you know and 1,000 questions that you don't know. I know that this can be very overwhelming. It can be it can come with some inherent anxieties about approaching the process and the world of unknowns. So there are world-class physicians here that are going to address all of your medical questions, and I'm sure that they have good news to share when it comes to surrogacy arrangements. But I do also have some good news to share when it comes to the legal side. As an introductory note, anytime I get the opportunity to speak to a group like this, I want to make sure that that if you walk away with nothing else, you walk away with a couple of points. First of all, why do I need to talk to a lawyer? Right? It's a good question that I get often. What is the role of the attorney in a surrogacy arrangement or in an egg donation arrangement, but specifically in any collaborative reproduction arrangement? You should be represented by independent counsel, meaning each party receives their own independent legal advice. That may be as a threshold matter, or there may be statutory requirements that both parties are represented by independent attorneys. And as many of the physicians may attest to here, their clinic will require that both parties are represented by independent counsel. In fact, they may tell you that they will not begin any medical procedures until you have spoken to a lawyer and that you have come to an agreement between the parties, and that lawyer is providing legal clearance to that clinic. One other important point that I'm certain that you will receive a lot of good ideas from this panel, but let me give you one very bad idea. Do not Google gestational surrogacy agreement and rely on that, okay? It's a very, very bad idea, okay? It's the same as self-diagnosing yourself with your symptoms online. They're all bad ideas. Don't do it, okay? Every situation, every arrangement, every surrogacy arrangement is unique. Plus the laws of the jurisdiction that you're in, or where your surrogate resides, or where she intends to deliver, are going to be different, okay? And those laws are going to govern your arrangement. So this is probably not the last time I'm going to say it today, but you should consult an attorney that's licensed in your home state, okay? That's a good start. That may not be where you end up, but that's always a very good start, okay? I'm gonna pass it on, but I just want to make one other very important point from it as an introductory matter, which is that There's a lot of good news when it comes to the legal process. Do not be afraid of the legal process, okay? Just like, the physicians here and their colleagues, they're making advances in the science. It looks different than when I was a patient, okay? In the same way, the law is constantly adapting. We are way, way slower than the scientists here. No question about it. The law is much slower to adapt. But while it's not as swiftly as we would like, the law is evolving in a way that makes these types of agreements for these arrangements, depending on the jurisdiction, valid and enforceable. So that's, as an introductory matter, you got to think I have to have legal representation at some point in these collaborative reproduction arrangements, and we can talk about some of the details based on your questions.
If I can make a point to some of the things that you said about the importance of having an attorney. I'd like to add that the attorney should have a specialty in either reproductive medicine or surrogacy law, because I've had patients over the years with a contract from an attorney who does real estate closing and does wills, and we won't accept it, number one, in our practice, but number two, it's really, really important, like you said, to have a proper attorney who is familiar with that state's surrogacy law, and it should be a specialty attorney, not just any attorney. I mean, maybe that sounds like it's a simple point, and maybe it doesn't need to be said, but it does need to be said.
Yeah, thank you so much. Staci, can you walk us through the process? So if someone, an intended parents, wanted to seek the surrogacy pathway, can you give us an idea of how that process looked like?
Absolutely. So our role here at Family Source, we've been doing this for almost 14 years now. And just like Ryan, I've also been in the audience as well. I'm a previous intended parent myself. So my husband and I, we went through surrogacy to build our family, and our son now he just turned 15. So it was many, many years ago. So it's pretty exciting how just the world of surrogacy has completely evolved and improved, not only on the medical side, but also the legal side, I feel, very regulated. But definitely once intended parents do reach out to us, it is our goal to really make the best match possible with their gestational carrier or gestational surrogate. So we have a very active marketing team. We have our intake team for screening the surrogates, where I feel that's extremely crucial. So before we even present a profile of a surrogate to the intended parents, we have already received and reviewed the surrogates' previous medical records, her delivery records, her pregnancy records, the psychological evaluation, criminal background check, clearance from her OB stating that she's a healthy candidate to become pregnant as a surrogate. So before we even present her profile to intended parents, we make sure that that is pretty much completed at that point. So again, our role here is to really check all the boxes and make sure that the surrogates are cleared, ready to go. And I would say maybe only about 15 to 20% of the surrogates who actually apply end up entering in our program and becoming a match with intended parents. So again, super important, that the surrogates are really pre-screened as much as we can. We're not medical experts, but we really try to gather all those records and get everything ready to go. In addition to that is the support that we provide for intended parents as well as surrogates. So we have on staff, we have social workers. We also have support groups for the intended parents and the surrogates. So in addition to the support that they have individually, they also have it within our agency. So, and just really to guide them with our expertise. Many of our intended parents come to us and they're in the very beginning stages. They don't have an attorney. They don't have a fertility center. So they really are looking upon us to guide them in the best and in the right direction. So we'll start, just really educating them. We will recommend fertility centers, attorneys, and like Ryan said, the legal portion is so important. And Dr. Roseff, that the legal definitely make sure that it is an attorney who specializes in reproductive law, because there's so many attendant parents who they really want to try to cut corners a little bit and save a little bit of money. And I understand it's a very expensive process. However, that is definitely where you do not want to cut corners, is the legal. So we guide them, recommend the attorneys again. So realistically, our team is just, we have a wonderful group of professionals here at our agency that have 17 of us here have had personal experience as well, whether as a surrogate, donor, intended parent. So I think that really, I think that also gives the surrogates and the intended parents, as well as donors, some extra support and trust in our agency. So, but again, we guide them from the time that they reach out to us until after the babies are born. So I personally, I have still many wonderful relationships with our intended parents from 14 years ago. So it's pretty great.
Thank you so much. From a medical perspective, how does that process look like? And I'll start with Dr. Chen. If you can walk us through the, patient surrogates enrollment and screening and all, just a general view of how that process looks like.
There can be a lot of different reasons for somebody to need donor egg or surrogacy, and donor egg is much more common than surrogacy. And so the most common reason is previously failed in vitro fertilization with your own eggs. Surrogacy could be a medical issue, like somebody has cancer of the uterus and gets a hysterectomy, or has cardiac disease. But we're also seeing a lot of gay couples using donor egg and surrogacy to conceive their families. And we're very lucky in New Jersey that some gay couples do have some coverage through their insurance, because our legislation is supportive of that. But it can be expensive. So a lot of times what I will see is, sometimes I've known the patient for many, many years, and we've tried other treatments and then come to donor egg that way. But sometimes people come knowing they need donor egg or knowing they need surrogacy and see me from that way. And I try to put all the balls in the air at once. We can, if we're doing both donor egg and surrogacy, it is much easier to get the egg donor, because most of our egg donors are anonymous, and there are egg banks we work with as well as fresh donors. Whereas the surrogacy relationship is an intense one. You're essentially living with somebody. They're becoming part of your family at least for about a year, whether you decide to continue the relationship or not. So there's so many layers. And honestly, my part is very easy, because I put all the other experts together. When a doctor has a nice uterus, nice eggs, and a few sperm, it's very, for us, it's very easy to make a baby. It's honestly, it's all these other facets, like the legal aspect is huge, psychological aspect, logistics, financial, social aspects, all of those. That's where we need good lawyers, good agencies, and things like that. And it's my job not to be a lawyer or an agency or a travel agent or any of those things, but to make sure that we put together all those resources for the patient, and that they get a good team. And there's a lot of different resources out there, and I like to give my patients choices, so we don't work with just one lawyer or just one agency. We like to give people many choices, because there are a lot of different ways to go. But so that is a little bit of an overview.
Thank you so much. Dr. Roseff, can you tell us about your process?
Sure. Do you want to talk about donor egg, surrogacy, or both?
You can talk about both, but I think I'm emphasizing a little bit more surrogacy at the moment.
Right. Okay. So at IVF MD in South Florida, my practice, we do a lot of we use a lot of egg donors. We have, certainly like Dr. Chen said, less call for surrogacy. But the law in the state of Florida is that my understanding is it's illegal to use a gestational carrier or a surrogate in the state of Florida unless there's a condition that a woman has that would cause her to have ill health or be a threat to her life or the health or the life of her potential baby. So I've had patients who come to me and they say, I want to use a surrogate. And I'll say, why do you want or need to use a surrogate? And they'll say, I don't want to have stretch marks, and so I want someone else to carry the baby. And I have to tell them that's not legal in the state of Florida. Or I don't want to take time off from work, so rather than take maternity leave, I'll just use the surrogate. And my understanding, and Ryan, you can please correct me if you know or if I'm wrong, my understanding is we can't do that. So I have patients who come to me who went through in vitro fertilization. We transferred an embryo. She conceived, she delivered her baby. And then after she delivered, she had a stroke and she's paralyzed half her body. She comes to me with crutches or a walker and a limp, and she's having disability problems. And her hematologist said, you are not to get pregnant again. It's too dangerous to your health, and you're going to need a gestational carrier. So we have all different types of situations where people come in. It's not very common, but like I said, we do gestational surrogacy quite a bit. We have 6 practice locations. We have 13 doctors in the practice. So being that it's a fairly large practice, we have a lot of patients and therefore quite a bit of need for surrogacy and also for egg donation in certain populations. And because there are so many I's to dot and so many T's to cross and so many important moving parts of the equation for success, we have in our practice a third-party reproduction department. We have coordinators in our third-party department. Third party is donor egg, surrogacy, and other parties. And our third-party department consults with each patient to discuss, okay, you're going to need a proper attorney, and I see you live in this location, so here are some of the attorneys that we like to work with who specialize in this, who are not far away from you. Although today with virtual consultations, it's really much easier. We don't have to find that specialty attorney that's within a few miles away because it could be a virtual consultation, but eventually contracts have to be signed and so on and so forth. So I see my patient or couple, either they need to go through in vitro fertilization to create embryos that will be frozen and subsequently used to transfer to a gestational carrier. We have, I don't know if we're going to get into the differences between traditional surrogacy and gestational carrier, but my practice does not do traditional surrogacy. We just use gestational carriers where we take the sperm and the egg, perhaps from the intended parent, and then we create the embryo that gets transferred into the gestational carrier. So it's a process, consultation, in vitro fertilization, if it hasn't already occurred, or if it has already occurred and that we have frozen embryos, then after third-party department consultation and referral to an agency or agencies that we like to work with in South Florida and specialty attorneys, those parts all come together. You had said before, I think it was Staci who had said, that you get the medical records from your potential surrogates and you get a lot of information about them. And one of the things that I do is I request those medical records from the surrogate or the potential surrogate as well. I want to see everything about her to make sure that even though the agency, with all due respect, has approved someone as a gestational carrier, I've seen some agencies who have carriers who are obese, and I love their profiles. I love everything about them. But once we get a BMI and we find they're obese, I recommend lifestyle changes and improvement of certain factors so that when we do move forward, we'll have the best chance of success, because those things can certainly affect the outcome. I meet with the surrogate or the potential carrier and take a history. I do a physical examination, and then I do a procedure, and I'm sure Dr. Chen, you do the same thing. And Dr. Evans, you do, I would assume you would do the same thing. I do procedures like a saline infusion sonogram procedure to make sure that the uterine cavity is free and clear for embryo, pregnancy, implantation. So we do some things that give us the best chance that we'll have a successful outcome. Then we move forward with the procedures, the treatment. And I'm sure it's standard, it's pretty standard throughout. You know, we have other experts here who are fertility docs who do this, we all do pretty much the same thing, but that's the process with me.
Yeah, and we're gonna go into more details later on the screenings that are available for surrogates. Dr. Evans, what's your workflow or procedure look like when it comes to surrogacy egg donation?
And normally what I would do is speak with the intended parents about choosing a surrogate. I like to start with that and give them some ideas about what they should be looking for when they're trying to choose a surrogate, because I think it's really unknown, you know, what should this person be like. And so I discussed with them that we really would love to have a surrogate who's had at least a successful pregnancy before. We don't want somebody who's had medical complications in pregnancies or preterm births or those types of things, because we want a really good outcome. I discussed they should have a really nice medical history. A surrogate is somebody you're going to have a relationship with. So obviously somebody that you connect with, somebody that you trust. Someone who has a normal body mass index is preferred because it will be a lower risk pregnancy. And also someone who has a good support system, because oftentimes surrogates have young children of their own, and they may need to go on bed rest or, you know, be hospitalized for something. And you want to make sure that they have a good support system at home who's really with them on this journey. And then typically the intended parents will work with agencies to find a surrogate, and they want to work with an agency and with a physician who has really good, where everyone's communicating well with each other, because it is a big process and it's kind of daunting in a way, and you want to feel like you have really good communications with everyone who's helping you out. Once a surrogate is chosen, or they think that they're interested in this one surrogate or two surrogates, I also like to do what Dr. Roseff does, which is get the records. I want to have their previous medical records. I want to read about their deliveries. I want to see all of those tests that were done. And, sometimes we will see things as we go through that record where I think, oh, no, that's not okay. Something happened that was very complicated, where you're going to be concerned about the outcome. So I like to review those ahead of time so that we don't need to go through with a consultation or cost or things that may be incurred for the intended parents if they don't need to. If the records look good, then I set up a consultation to meet with the surrogate. And during that consultation, I would do a complete history with them, going over their previous pregnancy history, make sure there's nothing that was missed in those records, talk about their medical history, menstrual history, etc. And then if that sounds good, then they would have, I do a complete physical exam and a fluid ultrasound, like you talked about before, to evaluate the uterine cavity, make sure there's no issues with polyps or fibroids or things that may stop a pregnancy from attaching. And then they will have screening tests as well. And I think you said you would get into that more, but there's a whole list of screening tests that need to be done. Most of them are blood tests, infectious disease screening, preconception screening. So we would want all of that to be done as well. The surrogate will have also had a psychological clearance. And at this point, if everything is looking really good, then we do legal clearance. We're like, okay, all the medical stuff is looking good. I think that it's appropriate to move forward with this surrogate, and the intended parents feel good about it. Then we would want a legal clearance with a reproductive attorney. And once that legal clearance is received, then we move forward with the treatment cycle.
Just wanted to
And
follow
to-
up on one thing that
I think
Dr.
we're-
Roseff, sorry,
No, that's fine.
he mentioned the not being able to proceed for necessarily cosmetic reasons, and we talked about a little bit when I started about how there's not much uniformity across states when it comes to the laws that are applied in, say, Florida, where Dr. Roseff is, or in Illinois, where I am. And it even extends to that particular matter. In Illinois, we refer to it as a medical need. That's what the statute says. Just the intended parent has to have a medical need in order to pursue gestational surrogacy. I'm not a Florida attorney, but I only know this because that's where the surrogate who carried my child resides, is that they refer to them as not intended mother or intended father. They refer to them as commissioning couple. And the commissioning couple has to have evidence that they cannot physically gestate a pregnancy to term, number one, or it will cause physical health, or it will cause damage to the physical health of the commissioning mother. So while it's the same result, yeah, right. While it's the same result, it's viewed a little bit differently. And that's, state legislatures drafting them different ways, or the state of Illinois drafted their Gestational Surrogacy Act in 2005, and I think Florida was maybe 7 or 8 years later. So they've evolved a little bit from the Illinois Gestational Surrogacy Act. So.
Okay. I was just going to add on as well to Dr. Evans and Dr. Roseff. In terms of the medical records, I was basically insinuating that we will collect those records as an agency. We do have a midwife that also works in our surrogacy acceptance team. So she's been wonderful at weeding out, maybe surrogates who certainly should not be accepted. But most importantly, we certainly understand that the medical professionals are the ones who do the final review for sure. But it's important as an agency, for example, if the surrogates had 3 or 4 children, we want to make sure that on our end, we are collecting all of those records. So when we send the information your way, you have everything all at once. So for example, we're not sending you everything, but we're missing records 2 and 3 of her children in delivery. So that was my perspective in terms of, we collect all that information. We will share those records with you for your review, oftentimes before we even share either profiles with the surrogates and attended parents, or move on to a match meeting. We want to make sure that everything looks acceptable on your end. And I know that many different fertility centers, they have, such a fluctuation of criteria, whether it's BMI or max number of childbirths, or, so we will know exactly, what your outlook is on that. So maybe where one fertility center, their BMI may be 30, where the other one may be 34. So we're going to know that up front. So when we're sharing profiles with your clients, your patients, and our intended parents, we're going to know exactly what surrogate's going to fit into your acceptance. So before we even share those profiles, we know that. So again, that's where the importance comes from in terms of collecting all their information before we even pass this on.
I agree.
And so
No,
we don't want to be sending things to you bits and pieces.
Yeah. That's super important, is for patients to know they can't just use any agency. They have to use an agency that has experience, that knows what they're talking about, that works well with your provider, because all of that extra work, even though you're not the medical professional and you're not going to finalize the treatment, that all of that pre-work is huge in helping out the intended parents, because otherwise they can waste enormous amounts of time and money just, looking at the wrong candidates.
Absolutely. We want to make sure that we're really eliminating any unnecessary, time or work. And even on the medical experts end, we don't want to waste your time. We know going through, sometimes 4 or 5 different sets of childbirths, it takes quite a while to review those records. So we really want to eliminate that burden. So that was my perspective in terms of that. So yeah, absolutely.
Thank you so much. We're going to go into the qualification of a surrogate and the screening and all that aspect. So we have a question from one of our attendees. Miriam, if you can read that question for us? I think it's number 3.
Sure. One patient asks, what are the qualifications for being a surrogate? And then they also have follow-up questions of what are the necessary screenings required to become a surrogate? And lastly, what is the compensation for egg donors and surrogates?
Very good. So we will start maybe with the medical team, and then we go into the agency aspects of surrogacy and then the legal aspects. So let's start with the medical team. Let's start with you, Dr. Roseff.
So for the surrogate and the screening process, we have a checklist. Our third-party reproduction department has a checklist for things that the surrogate has to qualify for. So like someone had said before, infectious diseases, I think Dr. Evans had said, it's mostly blood testing for all kinds of substances and infections and health conditions to make sure that we feel comfortable having this person carry the pregnancy. Another test that I do, that we all do evidently with our potential surrogates, is what Dr. Evans had referred to as a liquid sonogram. We instill a sterile solution of saline into the uterus, and I do an ultrasound with 3-dimensional 3D imaging of the inside of the uterus to make sure, like you had said before, we don't have polyps, little growths, we don't have fibroids. If there's a prior C-section, there could be scar tissue. And in fact, getting into the C-section, cesarean section realm, when I have a carrier who had a prior C-section or prior instrumentation, let's say she had a miscarriage and had a procedure called D&C and an instrument was inserted into her uterus. If she's had any kind of surgical procedure on the uterus, I will also go above the standard testing and take a small, tiny sample of the lining inside her uterus. It's called an endometrial biopsy, and I'll send it to a laboratory for what we call special immunostaining to see if she has an ongoing infection inside her uterus. I found at least 10% of my patients who've had a prior cesarean section have a chronic, low-grade, ongoing infection inside the uterus. They wouldn't have pain, they wouldn't have fever, they wouldn't have bleeding, they wouldn't have a discharge. And so I check for that. And if there's an infection, treat it, and then repeat the test to make sure that the infection cleared. Some of the blood testing that I do that some people would consider to be controversial, there is a subspecialty of reproductive medicine called reproductive immunology. And some of the testing that I do includes testing for something called natural killer cells, because it's been found if there's an excessive activity, high activity of natural killer cell activity, it can have a negative impact on the embryo implanting. It can increase the risk of miscarriage. So I do testing such as that and certainly treat that if there's an abnormality of that. So as far as the screening, history, physical examination, mostly blood testing, saline sonogram, endometrial biopsy, and that's it for screening of the surrogate. I know that there were other questions and I didn't write them down. Miriam, was there a second part to the question?
Qualifications for being a surrogate, and then compensation for egg donors and surrogates. Maybe that would be a question.
Right, so I think all of that really gets more into the realm of Staci, the agencies, as far as qualifications, because like you said, Staci, the majority of women who perhaps apply may be rejected. So you have certain qualifications, and then the compensations. I'm not involved in the compensation whatsoever, so maybe somebody else can speak to that.
Yeah, we will continue with the medical team, and then after that, Staci, you can cover the qualification, and I'll go with Dr. Evans.
For the screening test.
The screenings.
Sure. So we start with the blood screening tests, and the blood screening tests are infectious disease screening. And I also do screens that I call preconception screens. And these are basically blood tests that look at certain things that I think are really important in pregnancy, things we want to know about to make sure that somebody has a safe and successful pregnancy. So that would include things like their blood type, a complete blood count, a thyroid panel to look and see what the thyroid is like. We look to see if they're immune to things like rubella and varicella, which could be very bad, infections to get in terms of effects on a fetus. So there's another group of blood tests that I call preconception screens. So they have infectious disease screening, preconception screens. And then I do a complete physical exam for all of the surrogates that I see. So that includes a general exam, heart and lung exam, abdominal exam. I do a pelvic exam, a pap smear, a breast exam. And I'm basically doing those just to make sure that there's nothing obvious that's a medical problem that could be found on physical exam. I want to make sure somebody doesn't have a breast mass, like a small breast cancer or something like that could grow during pregnancy. So that's part of the screening tests for my patients that I see. And then the next thing is the fluid ultrasound. And that's the one where that fluid is placed into the uterine cavity with a little catheter. That's done in the office. And then I look with ultrasound to make sure that there's nothing there that's concerning. And if there is something there that looks like a polyp or a fibroid or something, then the next step would be a procedure called a hysteroscopy, where a camera is placed through the cervix and into the uterus if something would need to be removed. And those are, and then the psychological clearance, that's not something we do in our office, but that's something that they would do with a psychologist.
So you have a psychologist added to your team, outsource service?
Yeah.
Service.
Yeah.
Very good. Dr. Chen?
So I do all of those same things. I see a question in here about drug screening. We do drug screening for the carriers and for the donors. And I check for like diabetes. I like people to be on prenatal vitamins. We want everybody, the egg donor, the intended parent, and the gestational carrier to optimize their health as much as possible, because we know that preconception health has an impact upon the health of the pregnancy, the outcome of the pregnancy, and now there's evidence that that even has an epigenetic effect into childhood and adulthood for these children. So what we're doing now can, have a significant impact on the health of the next generation. So we really like to emphasize being healthy. And I think, when you have, there's the tragedy often of needing a gestational carrier or needing an egg donor. Many patients come to this because they've experienced loss and infertility and they've struggled to conceive. But the bright side of it is this is a real opportunity to try to, set yourself up for the healthy, the best chance at a healthy baby as possible. And so, I think the criteria for a gestational carrier to get pregnant, I think all the doctors would agree, is, we set the bar much higher for gestational carriers than we do for intended parents. Intended parents might have some risks, and we still help them to conceive, but gestational carriers really have to reach a very high mark. So, and I'm sure Staci sees that as well, because, you're putting so much into this. And then the other thing with gestational carriers, and I wanted to ask Staci about this because I do tell this to my patients a lot, that I think gestational carriers also have to accept the intended parents. It's a two-way relationship. And
Absolutely.
the intended parents, right? The intended parents can set themselves up as being more attractive to a gestational carrier by having some frozen embryos already. And if you're, if you have PGT normal embryos or donor embryos, the gestational carrier's goal is to get pregnant and have a healthy baby. That's what she really wants. And obviously the more normal or nicer embryos we have, the better position we're in. So I don't know, Nabil, did I answer the question you wanted me to answer?
Yeah, absolutely. Later on, we're gonna go into genetics and all that aspect, but for now, I think this is great. Stacy, if you can walk us through the qualification
Yeah,
and the
sure.
compensation aspects.
Yeah, absolutely. And in terms of the qualifications, we have, there's going to be a variety. For example, that, like I was saying earlier, some fertility centers, you will have your criteria, and it's going to be a little different than others. But in order for us to accept a surrogate, obviously they have to have had at least one pregnancy and a healthy pregnancy full term. So that's super important. And then in terms of the medical, in addition to that, obviously there's C-sections, maximum C-sections of 3. Again, I know some fertility centers may be 2 and some are 3. Ours to accept a surrogate is 3. You have BMI. The surrogate has to be under a specific BMI. With us, it's 35. And I know that tends to be on the higher side, but there are many fertility centers who are okay with that. So that is the qualification in terms of the medical. Of course, they have to obviously not be on, not have a history of depression or be on any kind of anxiety or depression medications. It's important that they have overall stability in their life. And that is not only on their support and their health, but financial as well. They have to be financially stable. They cannot be on any sort of government assistance. So that's really important as well. But in terms of the compensation,
Stacey, do you actually run a credit check on your carriers? Do you do? Because some people do, some people don't.
Right, we don't do a credit check, but we definitely run a criminal background check on the surrogate as well as her partner. So if she has a partner, it's also ran on the partner as well. Same with psychological evaluations. Yeah, they have to have both parties have to have the psychological evaluation and screening. And again, that's prior to the matching process. So we like to have that done up front. And then in terms of the compensation, the surrogates within our program, generally the base compensation plus the monthly incidentals is a total of $40,000. And that compensation would start once we have a heartbeat confirmation. So it's typically broken up into a period of 10 months, 10 payments. So it'd be $4,000 once we have that confirmed pregnancy via heartbeat confirmation. And then in addition to the base compensation, you have the additional payments that they would receive, the surrogates would receive, for example, embryo transfer fee, maternity clothes allowance, starter medication fee. If it's multiples, there's a multiple fee. If there's a C-section, then there's a C-section fee that they would also receive. And then of course, lost wages. And that's always one of the unknowns. We don't know if there's, how much the lost wages are going to be. So, intended parents, they could match with a surrogate who maybe is a stay-at-home mom. So that's obviously none. Or it could be a surrogate who she could be the breadwinner of her family and make a very good salary. So that's always the unknowns. But when we do share a profile of a surrogate with the intended parents, all of that is fully disclosed. So they'll know exactly what the compensation is, what the insurance coverage is, all the additional incidentals, all of that is very transparent on the profile. We share that with the intended parents. The surrogate or the donor's compensation, I'll touch on that really quick. You had asked that. With us, we do cap it at 10,000. So it's 7 to 10,000. So if it's a first time egg donor, it's 7,000, second time is 8, 9 is for the third, and then 4th, 5th, and 6th, they receive the 10,000 for the compensation. So that's for the egg donor.
Thank you so much. Ryan, when you represent an intended parents who is seeking a surrogate, I'm sure you go through those qualifications in some ways, right? To give the best advice for an intended parents. How does it look like from your perspective?
Yeah, I love this question just because there's a lot of requirements that a lot of hurdles that a gestational carrier will have to clear before they even get to me, right? Most importantly, they are going to have to be screened from a medical perspective, from a mental health perspective, by the agency is going to have their own requirements. And a lot of those will overlap with what the law requires, right? And so if a gestational surrogate is being represented by me, I need to make sure that she is qualified under the law of the state of Illinois. And that could apply to whatever jurisdiction in which the gestational surrogate resides and intends to deliver. So for example, in the state of Illinois, you have to be at least 21 years old. You have to have delivered your own child. You have to have undergone a mental health assessment. You have to have had the medical screening completed. And you also have to have evidence of a health insurance policy for major medical and hospitalization for the duration of the surrogacy arrangement, okay? Now that does not end the analysis. The analysis also extends to the intended parents. In Illinois, and I hate to sound like a broken record, uniformity eludes us. This is not the same in every state, but in Illinois, the gestational surrogacy arrangement requires that at least one of the intended parents have contributed a gamete to the embryo that will be transferred to the gestational surrogate. So in other words, it can't be an embryo donation and then
that's fascinating.
Listen, yeah. Okay. So let me caveat that. This is what lawyers' favorite answer always is. It depends, right? And so this depends on whether or not you want to pursue some sort of adoption, which is what would have to happen, right? If you were using an embryo donation and a gestational surrogate, okay?
So then you could adopt as opposed to getting right on the birth certificate. Whereas if one person was related, you wouldn't have to adopt.
Dr. Chen, how much time we got here? So let me just answer it this way.
Yeah, because there are other scenarios too. Older female couples.
Totally.
Donor egg, donor sperm.
Let me try and answer Dr. Chen's question just as quickly as I possibly can. Every state has their own separate parentage requirements when it comes time to establish parentage in the state where the child is going to be delivered. It can be a pre-birth state, it could be a post-birth state, it could be like Illinois, it could be a pre-birth administrative state. Here, we do not require any court intervention. We just have to file certification statements with the delivery hospital and with the state of Illinois, and then the intended parents' names will go on the birth certificate, okay? Now, if there is any deviation from the Illinois Gestational Surrogacy Act, which is the circumstance that we just discussed, an embryo donation carried by a gestational surrogate, then we have to start thinking about stepping outside of the Gestational Surrogacy Act and the processes that are required in order to establish parentage. So it's tricky, but it can be done, certainly. So I don't know if that answers your question.
We need a reproductive lawyer.
Yes.
Right?
100%.
Right.
It's very complicated.
Are there any
very complicated.
Are there any states that are more flexible when it comes to requiring one of the parents to contribute?
There are, but Nabil, your child is not going to spend their whole life in that state. That's what I tell my New Jersey couples. Yes, you have two women, they're married, their child is on the birth certificate. That's very nice. You are parents, you're both parents, legal parents in New Jersey, but you're not that way outside of New Jersey. You need a lawyer to make sure you can bring this child anywhere and still be safe and still be considered a parent, a legal parent.
Yeah.
Being on the birth certificate, being married, not enough.
I have a question for you, Ryan, in terms of that, actually. Something that's been brought up quite frequently is that you had mentioned earlier, Ryan, about having the attorney in the state where you live, right? I know with the surrogate, absolutely, but with the intended parents. And this has been a hot topic lately within the agency because we're seeing so many, obviously, intended parents who are matched with obviously surrogates not in the same state as them. What would your advice be? And I think I know your answer, but we're hearing again mixed ideas about this. Let's say the intended parent hypothetically is in Illinois, so they meet with you, and then they end up saying, yes, we want to work with Ryan, but they're still not yet matched with a surrogate. And then say this, they end up matching with a surrogate, hypothetically, let's say Texas. Now, do you think that the intended parents would be better off working with an attorney in the state of Texas, or are they fine with you in Illinois?
This is another question that eludes us, but let me try and answer it this way. I would be fine representing the intended parents in that situation, but I would also explain to them that at some point they're going to need a Texas attorney, because in order to establish parentage, they are going to have representation in the state of Texas. So while I answered the question differently at the beginning, I'm just going to tell you that my first recommendation is to always say, here are the names of 3 attorneys that I work with in the state of Texas. I would recommend using one of them. Okay. I'm not saying, you know, they could say, we absolutely want to work with you for the contract phase.
Yeah.
And that's, you know, there's a difference of opinion about that representation in the contract phase versus parentage. But I'll only say that my practice is to always refer them to someone who practices in the state in which the gestational surrogate intends to deliver. Okay, it's just this. There's that way. There's not a passing of the baton, so to speak, from the contract phase to the parentage phase.
Thank you.
Very good. We have Miriam. Can you give us another question from your list?
Our next question is, if a surrogate were to get pregnant on her own with her partner, what would the recourse and implications be for the intended parents or surrogacy agency?
Is this something that happens, that you have a surrogates that at some point they can conceive on their own in outside of what, you know, the contracts where
So I'm assuming pre-embryo transfer with the intended parents? Is that what they're implying? I'm assuming.
What question are you?
I guess a big ups.
I've never seen that.
Right.
But I suppose anything can happen.
So let me try and answer this real quickly.
Ryan would cover it in the contract ahead of time,
That's
right,
right.
Ryan?
That's right. That's right. There's an automatic termination if she's pregnant prior to she's pregnant prior to the embryo transfer, the arrangement would automatically terminate. That's a standard provision in gestational surrogacy agreements. Now, there was a case in 2017, I think, where a woman became pregnant after embryo transfer and then also was pregnant with her own child. Am I misremembering that? Did that happen?
It could have, I guess.
I guess it
or
could.
Either that or really like a National Enquirer story and somebody made it up, you know.
Okay, never mind. Moving on.
Let's say that was the situation, and let's say she ended up delivering a child that was genetically hers and her partner's, and not the intended parents. And throughout the entire journey, they thought, now,
well,
would you
from a legal perspective, she's still carrying the child of the intended parents. Okay, so we would treat that as if she is still only carrying the child of the intended parents. You know, there's some sort of
her biological child.
Even if it's a surrogate's biological child, and say they deliver.
I think this would end up in court, and
yeah,
it depends on the state.
Yeah, I don't see how that would hold
the
up.
surrogate may owe a lot of compensation back, I would assume, if it was her own biological child and not. Yeah, and the intended parents are paying the entire journey.
This sounds really complicated.
Hopefully, that would never happen.
Yeah, interesting.
I've never seen it happen. I like, knock on wood. I haven't had that happen.
Wood here.
And we do embryo transfer under ultrasound guidance, and if there was a pregnancy existing, we would see it.
We would see it. Yeah.
And I'm sure you guys have conditions to prevent that. And
well, they're suppressed. You know, they don't. We check for ovulation. Yeah. This is one reason to have these transfers done with medication, so that the carrier's own ovulation is suppressed. That, you know, those are some other things you can do to protect yourself. And I think the carriers are, you know, a good carrier is very, very dedicated to the mission. They take their jobs extremely seriously. These are not, you know, they're very, you know, the ones we've worked with, they're so serious about what they're doing. So I think it would be a rare occurrence.
A worst case scenario. It's a worst case scenario.
It is the worst case scenario, right? Absolutely. But Miriam, and to answer that question, prior to the embryo transfer. In 14 years, we have seen it happen where the surrogate does end up pregnant when she's matched with the intended parents, but obviously the transfer has not happened yet. So it could be prior to medical screening or after medical screening or during legal. It has happened. It's not common, but yes, it has happened. So obviously if that's the case, then the match is broken. And yes, intended parents may be upset because there could have already been expenses as far as medical screening, travel to get to the medical screening, or the legal, depending on how far they are. So in terms of, and then rematching, our agency would rematch them obviously at no additional cost with a new surrogate if that were to happen. But hopefully that, we try to avoid that, of course. They're very well, informed and educated, but you never know. Things could happen if they end up pregnant, then yes.
Yeah. Oh, thank you so much. We have a question from Nancy on matching, the matching process. Miriam, can you take us through that question?
Yes, Nancy says that her son was carried by a surrogate who happens to be a family member. She said, as we look to grow our family, we're interested in learning more about the process when an agency is involved in surrogate matching or selection.
So before we start answering the question, so matching can be from a surrogacy perspective, looking at what the intended parents wanted to be matched with. But on a medical perspective, I would like to hear about the screening, genetic screening, and all these tests that you would do to make sure that there is a compatibility there. And maybe we can start with you, Staci, and then we go into the medical field. How do you match? How does that matching works?
The matching, yep, the matching process it's definitely a mutual matching process. So we look at both sides of their criteria. So, if the surrogate, she lets us know what is important to her in terms of the intended parents that we match her with, or we share the profiles with her. So typically what we do is we'll share the intended parents profile with the surrogate first. And then assuming the surrogate is interested in moving forward, then we share her profile with the intended parents. But there are several things we want to look at when we're sharing profiles. For example, the surrogate, is she open to caring for international couples? Or does she want somebody who's domestic? And even if it's domestic, maybe more local or anywhere in the United States. The number of embryos to transfer, 1 or 2, that's really important. If the intended parents are wanting to transfer 2, which we're seeing that's really decreasing now, and we really try to educate them that transferring 1 is typically the best. But if the intended parents are transferring 2 embryos, we want to make sure that the surrogate's comfortable with that. There's also termination stance. It's very important. If a surrogate, for example, is pro-life, we need to make sure that the intended parents are also pro-life. So before we share any profiles, we're looking at the criteria for each. Intended parents, they also have their set of criteria too. Maybe they want to work with a surrogate who has insurance that would cover the pregnancy. So, and again, that's part of our intake process. When a surrogate has insurance, we review that, we share it with the professionals who also review it, and we only will share those profiles. So again, there's a lot that goes into the matching, and it's just as important that the surrogate has shared profiles that meet her criteria, and then obviously vice versa.
Thank you so much.
Staci, I feel like we're seeing more insurance companies that are excluding specifically gestational carrier pregnancies from their policies.
I've seen a pretty steady amount. Again, we work with surrogates throughout the United States, as long as obviously they live in a legally friendly state. But I would say probably it's right around 60% of the surrogates who work through our agency do have insurance. So that's a good thing. But yes, there are definitely the ones that have that flat out exclusion. And so we have to obviously look at Plan B at that point.
Okay.
Dr. Chen, do you do genetic screening for, surrogates that or egg donors that are going through that process?
The genetic screening is very important for the egg donors. We do not, it's not important for the carriers. They have an epigenetic, I guess, impact upon the pregnancy. Like if they eat too much sugar or they drink alcohol, that would have an epigenetic impact upon the pregnancy, but their own nuclear genetics should not impact the pregnancy. So where genetic screening becomes really important is the person who's giving the sperm genetics and the egg genetics. And we have to make sure that is a relatively low risk match. And again, this is another kind of golden opportunity to prevent severe genetic diseases because we can screen and plan ahead of time. And I think most reproductive endocrinologists in this country, and I think also in Europe and Asia, are doing these big expanded screening panels where we're looking for like 100, 200, 300 diseases that, you know, most children born with these diseases, there's no family history. It's kind of, you know, these patients, the couples are hit by lightning. And yet if we find these silent genes in the sperm person and the egg person, we can prevent those things from happening. And with egg donation, of course, we can select a donor that does not have any mutations that match the sperm donor or the male partner. So, you know, that's a hugely important aspect. And I was just talking with a lot of genetic counselors today because it's complicated. And what is important to know is that it is very important, I think, to get a genetic counselor sign off because most physicians don't have formal, extensive genetic training. And even people that are genetic experts, like our counselors, are being inundated with massive amounts of increasing amounts of genetic information and increasing complexity of our genetic knowledge. So in general, we try to make sure there's no matching mutations between the person giving the egg and the person giving the sperm. Because if you have each of them has a silent mutation that does not impact their health, if both end up in the child, that child can be severely impacted. And some of these diseases are lethal. And but that's the simple version, and that's not always the case. And with the help of a genetic counselor, you can find out how complete is the screening. Sometimes the ethnic background and the family history can impact upon the risks that the counselor gives. And some of these genes are funky genes, and some of these panels actually do contain genes that might even have some impact with just one gene, as opposed to only needing an impact with two genes. So genetics, I think the thing that's really, really important is no matter how much you know about genetics, we're always learning more. It's super complicated, and we always, before we say, okay, this is a genetically reasonable match, let's get a genetic counselor to sign off on that. I think that's one of the most critical aspects. Now, the good part is that most matches between a donor and the intended father, you know, it doesn't really narrow the playing field that much, because the chances that your egg donor will have the same mutations as you do is relatively low. It's usually in the 5% or less range. So it's not like you're going to be shut out of all these great donors just because you have mutations. All of us carry mutations. Mutations are part of nature and have some benefits as well. So everybody has mutations. We just have to make sure that you and your donor don't have any high risk implications.
Thank you so much. And I want to just add one more comments to your contribution here, is that some of these X-linked mutations, when they happen to occur in a child, in a male child, in a boy, they always have effects. So, and when you look at those panels that are available, commercially available for testing, they don't, most of them or all of them don't have all X-linked genes. And so we tend to kind of forget that risk. The reason why we know it is because sometimes we have, you know, patients who have a child through egg donation who is affected, and they wanted to avoid that in future pregnancies. And when we look at the donor has an X-linked syndrome. The donor themselves don't have any impacts on their health, but once they pass that into a child of a male gender, then it shows up quickly. Dr. Roseff, what is your
and that's
screening
because
process?
the donor has two X chromosomes, and the male child offspring only has one X chromosome. So
Exactly.
if it's on one of the X chromosomes, then in the female it may not show itself, but certainly in the male, where there's only one X and then the other is a Y chromosome, it would show itself.
Exactly.
Yeah.
Very good point.
Yeah.
Very good point.
And tell us, Dr. Roseff, about your process of screening. What do you screen for? And how do you approach genetic screening for egg donors?
The egg donors, so there are two kinds of egg donors. Again, I don't know how basic you want to get into the discussion, but we have what we call fresh egg donors, where we'll either have somebody in the next room that we've screened, or more commonly through an agency, an egg donor agency. And we also have frozen donor, where we have someone who previously was screened, stimulated with fertility injectable medication, had egg retrieval, and the eggs are frozen. But the screening process is the same for the egg donor as far as genetics, your question, Nabil. And that what we do at IVF MD is we do universal genetic screening. We currently screen for 283 genetic diseases or genetic mutations. And with the sperm person or the sperm donor, if the sperm donor, sperm source carries one or more genetic mutations, again, like you said before, we just have to make sure whether it's a fresh live donor or someone who has frozen her eggs in the egg bank, we have to make sure that that donor was screened for the genetic mutation from the sperm source or the mutations from the sperm source. And like Dr. Chen had said, while we all typically carry certain mutations here and there, the probability of having a man who is a carrier of phenylalanine hydroxylase deficiency and finding that same PhD, PKU genetic match in the egg donor would be extremely small. So, but we do universal genetic screening in everyone. And I always say every day, if it was in a perfect world, everyone on the planet, in my opinion, would or should do universal genetic screening before pregnancy. Because sadly, too many people, too many women walk into an OBGYN clinic or doctor's office carrying a baby with cystic fibrosis or Tay-Sachs or spinal muscular atrophy, and it's catastrophic. And had screening occurred prior to the pregnancy, then that would have been or should have been known, picked up. And we have methods where we can create embryos, genetically test the embryos for those genetic diseases, and transfer to a uterus, an unaffected one, or we can get a different sperm donor or a different egg donor. We have choices depending on where the genetic mutation is. And so we have choices, but not everybody is afforded those choices. But that's the way it is at IVF MD. We screen everyone.
Thank you so much. Dr. Evans, when it comes to carrier screening, maybe you can explain to us how you guys approach that. And at the same time, I would like you to address one of the questions we have on the chat, which is if the panels of the sperm donor or egg donor are different, how do you deal with that situation? Thank you.
Okay. So yeah, so we offer, well, to anyone who comes in, you know, whether they're using their own eggs or egg donor, sperm donor, anything, we offer recessive genetic carrier screening, which are these panels that can be done. And I think I would highly recommend it for anybody. to do this test prior to conception. It's done for all of the egg donors that we use, and it's done for sperm donors as well. And the panel that I use has a little over 300 disorders that are looked at. And there's a lot of different companies that do these. And so different practices will use different platforms and companies that they work with. It's best to have the egg source and sperm source tested with the same test, because that specific test from that specific company will look at specific mutations, and we want to make sure that we're looking at the same thing. And so if I know that somebody's choosing a sperm donor, for example, and that sperm donor was tested with a whatever test, I would do that same test for the person, for the person whose egg we're using, because I think it's really important that we're looking at the same exact thing. And like Dr. Chen said, I would definitely recommend that when somebody carries something, even if people don't match, they speak with a genetic counselor, because there is information, there's new information all the time. I'm getting updated information now about old tests saying, oh, now we know something new about this test that we didn't know a few months ago. And now we should contact the patients and let them know that this thing that we thought was okay might not be okay. So it's really important to speak with a genetic counselor, because they are the experts. There's so much data that they have to keep up on. They're going to be really good at explaining it to the intended parents, and letting them know about residual risks as well. We can't say, oh, you're negative, you're positive for this, but the donor isn't positive for that, so you're fine. It's not going to be a problem. I wouldn't really want to put that out there. I would want them to talk to a genetic counselor, and they can talk about residual risk, that at least for the mutations we know how to test for, things are looking good, but there can be things that we don't know about. And I think that that's really important, so people are very informed moving forward.
Absolutely. Thank you so much. We are coming to the end of the webinar. I would like to give you guys a couple of minutes to introduce your practice the same way we have done it in the past, and tell us what you do for patients, in this case, surrogates and donors and so forth. And I will start, let's start with the medical team, and then we go from there to Staci and then Ryan. And I'll start with you, Dr. Roseff.
So my name's Dr. Scott Roseff. I am board certified in reproductive endocrinology and infertility. I've been in practice for 31 years. Interestingly, Dr. Chen is on the chat. I'm the founder and the original director of the Institute for Reproductive Medicine and Science from St. Barnabas Medical Center in New Jersey. So I started that program in 1989. I served as director from 89 to 1993. And then I had private practice in New Jersey. So I was in New Jersey until 2006 for 17 years. Then I relocated to South Florida. I'm currently one of the 13 physicians at a group called IVF MD. We have 6 office locations throughout Central and South Florida. We're one of the largest IVF practices in the state of Florida, with among the highest success rates in the state. And I pride myself in the Boca Raton office on personalized, individualized care. So rather than take a number, just be part of a machine, I like to give every patient, every couple individualized care. I do testing with my donors and testing with my surrogates that I think goes above and beyond the norm. Like I said before, I strongly believe that high natural killer cell activity can knock off an embryo. And that's testing that I do that a lot of people don't do. And if it's abnormal, we treat that. I screen my patients for things like mercury. I had a patient this week whose blood mercury level was 33. Normal mercury in the blood should be no higher than 10. And yeah, she eats a lot of fish. And high mercury will have the potential to circulate through the blood, circulate to the eggs if it's an egg donor, circulate to the uterus if it's a surrogate. And mercury can be severely neurotoxic to a baby's brain. So I don't really see a lot of reproductive experts screening for lead and mercury and arsenic and some of the other reproductive toxins that are more common these days. So what I'm known for is dot a lot of I's, cross a lot of T's, and go above and beyond the norm for testing and treatment to get the highest chance of success in our patients.
Thank you so much. Dr. Chen?
Oh, Scott, I actually have one. Chantel is up here. She's amazing. So Dr. Roseff, one of his people that worked at his practice, moved to New Jersey, and she's amazing. And she says wonderful, wonderful things about you. And I think she's enjoying working with me in New
Thank
Jersey.
you. Well, she says wonderful things about you. She's certainly in constant. When she's not overwhelmed with work over by her boss, so Dr. Chen. She absolutely, and you know what, Serena, she says that you and I think you know this, have a lot of similarities. We're very much cut from a similar mold. We're very into health for our patients. You can go ahead and talk about it, but thank you for saying that's very nice.
So as Scott said, I'm the director Barnabas in New Jersey. We have 8 offices right now. We're adding more, mostly northern and central New Jersey. Right now we have 8 doctors, and you know, we do all kinds of reproductive services there. So if you're in New Jersey and you need a doctor, you know, give us a call.
If you're in Jersey, it's the only place to go.
Thank you. Dr. Evans?
Yeah, so I've been practicing medicine for over 20 years, originally as a general OBGYN, and then doing a fellowship and becoming a reproductive specialist. And I've been doing that for the past 16 years. And it really is where my passion is. And I'm so happy that I made the choice to switch my specialty. I would agree that, you know, one of the very most important things to me is really giving information. I like to really talk, you know, to the patients that I see about their fertility, the history behind what happens, you know, with our eggs and our sperm, how our bodies work. And I think that people are really empowered with information. I think that then they can take control and really be part of the team in making decisions for themselves and making really informed decisions. And I feel like I really am a person who's here to provide that information and then work together with you to come up with a good plan and something that really makes sense to you. Because I think that there isn't a template for how it should be done. I don't think that things have to go in a certain order and we have to start with this and then do this and then do this. I think everybody's different and their goals are different. And so I think that that's really my favorite part is giving the information and seeing how important that is and how it can really help people to move forward in a direction that makes sense to them. And I think the other thing that is really important to me is making sure that people are healthy and well through their treatment. Because ultimately, I mean, I tell people like, I have a huge goal for you to have a healthy child. But while that's happening and while we're working toward that goal, I want them to be healthy. I don't want anything to happen to them. I don't want anything to happen to their egg donor. I don't want anything to happen to their surrogate. And so that's another really important thing for me is the screening and making sure that we're doing things in a very, very safe way. And ultimately, of course, you know, my ultimate goal would be everyone's healthy and they have that healthy child to take home with them as well.
Thank you so much. Ryan?
Yeah, there's just one point that I wanted to make about the egg donation arrangements that I didn't get a chance to say. We talked a little bit about the gestational surrogacy arrangements and how that requires representation in a contract phase and in a parentage phase, right? When you're talking about egg donation, it does not necessarily require representation in that parentage arrangement, because there is a presumption when a woman walks into a hospital and delivers a child that she has established that parent-child relationship, okay? Versus in surrogacy, extra measures may need to be taken in order to confirm parentage. I just wanted to make that clear in case there was any confusion. I've been practicing law for 10 years, most of it as an assisted reproduction attorney. I used to be in corporate tax, and then found something that was far more interesting and far more personal to me. And so I have a solo practice in Chicago. I'm licensed to practice in Illinois and Missouri. Lawyers don't want to take more than one bar exam, so that's usually why it ends that way. At some point, maybe I am licensed to practice elsewhere, but I think just as important as the work that I do, which is representing gestational surrogates and donors and intended parents and recipient parents and donor arrangements, more often than not, I'm taking my lawyer hat off, and my wife and I volunteer our time to speak with people who are going through what we went through, okay, as a couple who could not conceive naturally. And so more time I spend speaking to people like that than I do my own clients. And so that was just a resource that we didn't feel was available to us. So we've tried to fill that gap, as to say, where do I turn? Who do I talk to? Well, it can start with us, but it's certainly not going to end with us. And so we want to make ourselves available to anyone who is experiencing that kind of frustration.
Thank you so much, Ryan. Staci?
Hello, thanks again for having me. It's been, as always, a pleasure. But my name is Staci Swiderski. I am the founder and the CEO here at Family Source Consultants. We opened the doors back in 2007, so it'll be 14 years in January. We really pride ourselves on making the best, matches between surrogates and intended parents and egg donors. So we're a full service surrogacy and egg donation agency. We do work with many international intended parents as well. Probably about 50% of our intended parents are international. We have a lovely international team who speak many different languages. We have representatives in France, China, the UK. So definitely we do have quite a few different language barriers that we can definitely handle. And really our ultimate goal is to make sure at the end of the day and the end of the journey, there is a healthy baby that is brought home by the intended parents. And, realistically, the intended parents are coming to us, as well as the surrogates, donors, to really receive that support and that guidance that we can give them. And, together with the team that I have here at Family Source, I feel that we can provide that for them, and definitely, recommend attorneys, fertility centers, whatever they need that's involved in third-party reproduction. I feel very confident that they're in really good hands with us.
Thank you so much. Well, with this, we are coming to the end of the webinar. Next week on Wednesday, actually not next week, but the week after, on November 4th, we're going to have another webinar on fertility preservation. So stay tuned. We'll send you some updates shortly. I would like to thank each one of you for helping us with the questions that patients had, and for bringing your expertise and your dedication, and that's very appreciated. Thank you so much, and I will see you in the next webinar. Thank you so much. Have a great day.
Thank you.
for having us.
Thank you. Have a good evening.
Take care.
Bye.
Bye-bye.